Hi everyone. Thanks for joining for DDU teaching for today. We'll be going through LV diastolic dysfunction today, and then next week we'll talk a little bit more about left atrial pressure, which is the real reason why we're trying to analyze diastolic dysfunction. But we'll start with this one, and we'll take it pretty slow because I know some of you guys are just starting off. Forgive me for those who are a bit more advanced, but I think it's really important to get some of the groundings in place before we take it to the next level. Okay, so over the next sort of 45 minutes, we'll talk about the why, how, who, and when to do diastolic dysfunction assessment in. I'll particularly talk about how to do accurate measuring and the imaging, because that's really important, because one of the things that I hope I'll try and emphasize again and again is the importance of repeated analysis when we're trying to look at things like left atrial pressure estimation, and indeed we can use it for looking at things like preload responsiveness and stuff like that. I mentioned a few clinically relevant diastolic function scenarios, but mainly I think the cases will be we'll look at more for next week when we're talking about left atrial pressure estimation. So we'll start with a relatively sort of straightforward case that we see not infrequently. 74-year-old guy with pneumonia. He'd been in hospital for 10 days. There's a MET call on the ward for respiratory distress, and he ends up coming to the intensive care unit and he needs mechanical ventilation. He's got a background which have significant risk factors for some form of heart failure, and that includes some diabetes, hypertension. He's known to have congestive heart failure, but with a normal echo. So we could call that heart failure with preserved ejection fraction, or HFpEF. Right? And with HFpEF, obviously, one of the things you get worried about is having significant diastolic dysfunction. So the big factors that jump out to me with this past medical history, first of all, with that hypertension means you've got risk of a thickened ventricle. And with those thickened ventricles, you've got an increased risk of diastolic dysfunction, particularly when you're starting to get a little bit older. And with that diastolic dysfunction, if you get fluid overloaded, for example, there's risk of getting pulmonary edema, and et cetera, et cetera. Okay, so when we look at this guy's heart, we see some pretty classic features of someone with a relatively, he's got some features of chronically raised pressures. So he's got a bit of hypertrophy in there. He's got some mitral annular calcification. I think that ejection fraction, you could say that would be mildly impaired. He's got a big left atrium, and the left atrium takes a little bit of time to dilate. My friend, the cardiologist, Faraz Pathano, I hope we'll get to talk to you at some stage. So he talks about the left atrium being the HbA1c of the heart, which I always thought was quite a nice comment. And what he means by that is that the left atrium doesn't dilate in 2 seconds. It takes a bit of time to dilate. And so if you've got a big left atrium, that's a sign of chronically elevated left ventricle end diastolic pressures. So if you've got a big left atrium, we've got to go thinking about diastolic dysfunction or raised left ventricle end diastolic pressures. You see that left atrium's pushed over to the right, suggesting raised left atrial pressures. So this guy had some clinical features of respiratory distress. He's got some 2D features there, potentially suggesting impaired LV relaxation or raised left ventricle end diastolic pressure, and maybe raised left atrial pressure as well. And Doppler can help us. So Doppler, we can look at the LV inflow, as we see here, with the E to A ratio. And here we can see the E to A ratio is greater than 2. And that's going to point towards someone having significantly elevated left ventricle end diastolic pressures or severe diastolic dysfunction. We can look at our tissue Doppler imaging, where we see markedly reduced E prime velocities. So the E prime is the early diastolic filling, and that E prime is the velocity of that mitral valve annulus moving towards the baseline. And moving away from the baseline, excuse me. And if it's less than 8 on the medial side, less than 10 on the lateral side, suggestive of raised left atrial filling pressures. The problem is you've got mitral annular calcification, which means that some of these things, they can lose some of their accuracy. And that's where having things such as looking at systolic flow blunting in your pulmonary veins can sometimes help. And here, so normally during systole, from the beginning of the QRS to the end of the T wave, we've normally got an S wave in there that looks bigger than the D wave. And if we're losing that in this scenario and we don't have horrible mitral regurg, that can be suggestive of significantly raised left atrial pressure. The other nice little sign I use, particularly with some of the mitral annular calcification, is this short decel time. So this deceleration time, less than 140 milliseconds, all points towards significantly raised LVEDP. Mix that in with some lung ultrasound, and here we can see some B lines in both sort of the anterior areas as well as in that sort of mid-axillary area, with those B lines going from the top to the bottom. We've got some big pleural effusions on both the left and the right. And so all of this would help point to me in that clinical context of someone with significant diastolic dysfunction. In the end of the day, the big thing is just suggesting whether he's got raised left atrial pressure or not, and certainly he would in this case. And therefore, the management's going to be, we've got to diurese this guy. We've got to get that preload down. We've got to try and provide supportive therapy. And what I mean by that is basically positive pressure ventilation. He is going to love that positive pressure ventilation because that will help reduce his left ventricle afterload. And along with some of those catecholamines that he was on, we've got to try and get those off, and all of those before we start looking towards weaning that ventilator. And this is the kind of guy as well with these heart failure issues and people who like positive pressure ventilation that would think about extubating these guys to non-invasive ventilation as like a stepwise reduction in their supportive therapy before we can look at just leaving them on high flow nasal prongs or, just on ordinary nasal prongs or even off oxygen. So that's an example of how we kind of use it in clinical practice. And now I'll just go through a few of the specifics about how to do that. So why are we going to do this, first of all? Well, the main reason, as I was saying, the main reason we want to try and look at diastolic dysfunction is to estimate left atrial pressure. I know left atrial pressure is probably a little bit different from pulmonary arterial occlusion pressure, but it's what we're going to use in some of the reference articles that we look at in some of the studies. They are different, but this is what is compared to in the literature. We can talk about the difference between left ventricle end diastolic pressure versus left atrial pressure. Sure, absolutely. I think in the end of the day, from a clinical relevance point of view, I care about raised left atrial pressure. I care whether a patient is going to need his positive pressure ventilation. He's going to need diuresis. They're going to need afterload reduction. They're going to need diuresis. So why we're doing it, I guess, just to assess their risk of being in respiratory failure. The clinical context is really important behind these guys. So as we're starting to look at diastolic dysfunction, let's consider how much catecholamines they're on. What's their fluid balance? Are they in respiratory embarrassment? Do they think clinically they look fluid overloaded? So trying to put that all together with our diastolic dysfunction assessment, and that includes looking at the E to A ratio of their mitral inflow velocities. We can look at our tissue Doppler imaging, where we look at particularly our E prime, that early movement of the mitral annulus towards the base of the heart. And we can compare the big E wave with the E prime from a tissue Doppler. We can look at our pulmonary veins, which I love looking at because you can't really fake it if they're abnormal. We can look at our decel time, which is that slope of that E wave. And we can look at our TR jet, particularly if that's greater than 2.8 meters per second, but that is in the absence of pulmonary hypertension. And what group are we going to want to look at? Well, we're going to want to look at the group that we're going to want to look at are those guys who we are worried about being fluid overloaded. So those guys that you're worried about, someone with ARDS, we're going to worry about it in those patients who have heart failure with preserved ejection fraction or heart failures with reduced ejection fraction. Those difficult to wean from the ventilator, is there a component of raised left atrial pressure? I think if we're seeing someone who's got pulmonary hypertension, particularly if they've got some form of right ventricle dysfunction, we want to make sure that right ventricle dysfunction is not being contributed by what we call a post-capillary pulmonary hypertension, as in raised left atrial pressure. Another group, and I don't have a huge amount of evidence to back this up, but another group that I think we've got to worry about it is those when we're starting nitric oxide. We talk about that in patients with ARDS, and we want to try and improve their oxygenation if they're, as a refractory therapy. If you give someone a pulmonary vasodilator while they've got raised left atrial pressure, you can it's almost like opening the floodgates, and you can put these guys into pulmonary edema. So before we start nitric oxide, inhaled nitric oxide, we should be looking to make sure their left atrial pressures aren't raised. Septic cardiomyopathy patients, I can show you some evidence of where it shows that those who have some form of diastolic dysfunction, it's associated with worse outcomes. So I think it's worth considering in these guys. And I think probably that might just be an indication of these guys that are at risk of fluid overload. It would be my guess. And that sort of brings us on to this idea of fluid administration. I'll also show some examples next week of when we give fluid administration, or particularly when we take it away. You can see when we're starting to reduce that left atrial pressure if we start assessing diastolic dysfunction. So all of these, this is a really sick cohort of patients. I'm not for 1 minute suggesting that diastolic dysfunction assessment with echo is perfect, but I find it really useful in these patients, and I think there is some evidence to back that up. I've already just described this, but when do I look for this? I look for it in those guys with respiratory failure, that group of patients I just spoke about. I want to try and make sure I've got, left atrial pressure as low as possible for extubating someone who's at risk of deterioration or needing reintubation or getting that weaning-induced pulmonary edema. And I'll use it to try and make sure I'm avoid fluid overloaded. And probably one of the kickers for this thing is you just got to do repeated analysis. Okay, so let's talk a little bit about the analysis. So LV diastolic dysfunction is an active process, so particularly this untwisting of the heart. And here you can see quite nicely as that left ventricle relaxes, it kind of got this elastic recoil, and that sucks blood in particularly during the early phase of diastolic dysfunction. As you start to get more dysfunction, that process becomes impaired. That's what we call impaired LV relaxation. That's particularly well seen if you look at the E prime of that mitral annulus. So as that impairs, you can see the active process becoming worse and worse. You need a pressure difference to try and make this flow happen. So as that left atrial pressure increases, that's going to help to drive that pressure forward as that pressure in the left ventricle gets worse and worse and worse. So as you get pressure building up in this left ventricle, you need to have that left atrial pressure to almost drive that pressure through. So you've got to try and balance these two forces out. And in the end of the day, it's all about left atrial pressure and making sure we can try and keep that as low as possible. Right, let's talk about some of the physiology. I'll just say a massive thanks to the late Andrew Hilton. He's the guy that taught me about how to do diastolic dysfunction. He made these slides, and I'll forever be grateful that he let me steal them off him, because they're beautifully made. He gave a great talk. He always talked beautifully on this, so I think about him when I'm talking about diastolic dysfunction. So this is standard Wiggers diagram, I think, as we call it. So this is the left ventricle pressures that you can see in there during systole and diastole, as I'm sure you've seen. The green line shows the aortic pressures, and you can see that that's kept above because of the atrial closure. And you can see the left atrial pressure there on the bottom, and take particular note of where the left atrial pressure is greater than the left ventricle pressure, because that's when we're going to start to get filling of the left ventricle. We can see that we've got our aortic valve opening and closure. We can see our mitral valve opening and closing, and that's what helps us sort of separate the systole from diastole in there. And during systole, obviously, we're getting ejection out into the aorta, and during diastole is when we're filling that left ventricle. And in between those, we've got the isovolumetric contraction and relaxation times. So the first part of diastole is this active relaxation process, and then the second part we talk about, it's the more of the passive filling, where we're getting it's dependent on some of the LV chamber compliance. And if we compare some of these to, here we've got the filling of that left ventricle, you can see that as blood gets ejected during systole, the volumes decrease. As you start to get into diastole, you get a rapid filling phase during the early or active phase of diastole, and then you get slow filling during the passive or compliant section or late part of diastole, and then with an atrial kick you get that final little bit of push of blood entering into the left ventricle. Okay, so it's that difference between the LV and LA pressures that causes the blood to flow into the ventricle. So during the early part of filling in normal diastolic dysfunction in normal ventricle, you get this rapid filling. So most of the blood happens during the early part of diastole, and then a little bit comes in during the atrial kick. And that's what the standard E and A wave looks like on diastolic dysfunction assessment of LV inflow. Okay. So I'll just show this to you again. So you've got the red is the early active phase of diastolic filling. Green is the passive phase of the atrial kick. And you get your E to A ratio. Okay. And that E to A wave filling is happening because we're getting this difference between the LV pressures and the LA pressures. Okay. The bigger the difference, the more filling you're going to get, right? And that's important when we start to think about preload. So show you how to do these things. So let's take a 70-year-old male. He's got worsening shortness of breath over a week. He's got some risk factors there to make you think that he's potentially got a bit of vascular path issues, maybe got some risk of heart failure with hypertension, ex-smoker. Have a look at his heart. He's got a reduced ejection fraction there. And if we want to then go and try and assess his filling pressures, we look at our apical 4-chamber view. We can put our color box over our mitral valve. We try and line up with the color Doppler flow. We can try and line up our Doppler cursor with the inflow there on the color flow. And we can put our pulse wave Doppler box at the end of the mitral valve, the tips of the mitral valve leaflet. And we get our mitral inflow pattern. So it flows above the baseline. And during early part of diastole, so that's after the T wave, during that early part, we get the E wave. And then with the atrial kick, you get the A wave. Okay. We want to try and measure this accurately, because if we're going to start to look at some of these values and compare ratios, you want to be able to measure it closely. So just a few tips and tricks about how to do that. So first of all, try and have it so you've only got 3 waves in sight. Try and get that baseline towards the bottom. Try and have the scale reduced. So what you're interested in is filling the screen. Try and reduce the gain so that you've got, you haven't got all the fuzz coming into it. Now you can see it's super bright here. Same patient, you can get different looking values. So we're looking for the modal velocity, as we call it. So just try and reduce that gain down and try and do the same thing every single time, right? We'll take it back to our patient now, and we're saying this gets affected by preload. Okay, so if we've got our normal filling of our E to A ratio, if I was to reduce that left atrial pressure, I don't know whether you saw, if I just go back and look at that blue line that we've got of left atrial pressure. If I was to let's say this guy's bleeding or dialysis or, I don't know, diuresis. If you reduce that left atrial pressure, well, you're going to reduce that pressure gradient, which means you're going to reduce some of those velocities coming through. On the other side, let's say I've actually given this guy a whole bunch of fluids, we can have a much greater difference. So that left atrial pressure is preload dependent. And so you can see these differences in the same patient with different preload statuses, I guess. And this can be really important when we're looking at, for example, let's say we're giving a patient fluid. If we're starting to give a patient too much fluid, you can start to see this E wave go up and up and up. And again, on the flip side, say we're trying to get someone off a ventilator, maybe this would be a good way to start trying to see if we're starting to reduce that left atrial pressure, if we start to see changes in the E to A ratio, for example. So we'll start with that E to A ratio, as you mentioned, but what else can we do? Well, we can do something called tissue Doppler, where you put the pulse wave Doppler box over the medial and lateral annulus of your left ventricle. And then by pressing the button that says tissue Doppler on the machine, or sometimes it's called, I forget what it's called on the GE machines. I think they call it, you've got to put the sort of color Doppler over it first. Oh, sorry, tissue Doppler over it first of all, and it puts everything in a funny red and blue color, and then you put your pulse wave on top of that. Sometimes they do it like that, and you get these standard looking curves that we can see up at the top here. And the different parts of these curves are, the first early part is called, the little blip down is called the E prime, as I've marked here. The second one down, which normally corresponds with the P wave, is the A prime. And then above here, we've got the S prime. And that can be a marker of systolic function. It's going to ask us to focus on the E prime first of all, and this E prime we can compare with the E prime on our with the E wave, excuse me, on our mitral valve inflow. But what you're going to notice first of all is that the difference between these two forms of pulse wave is partly the scale, right? So if you look at our standard pulse wave Doppler that we do of our mitral inflow, you can see here it's in meters per second. All right. And it's got these filters in here which are telling the machine to just ignore everything that's going at about 10 centimeters a second. And that's exactly what tissue Doppler is doing. It's the other way around almost, tissue Doppler. So tissue Doppler is in centimeters per second, and it does it completely the opposite to this. So in pulse wave Doppler, of the mitral inflow, it says ignore everything that's going at 10 centimeters per second. With tissue Doppler, it says ignore anything that's going faster than 10 meters a second. And that way it can just look at these slow moving structures, and the slow moving structure is the annulus, and so you can look at how that moves. So here you go. So early part of filling, E prime, late part of filling, A prime, during systole, S prime. Where do you measure it? Well, the idea is you're meant to measure it at the brightest portion. So it's really where this red line is what they suggest. So trying to turn down the gain so you don't have a lot of this kind of fuzz on the outside, turn that down, and then grab that brightest portion at that leading edge, if you like. And that's where you measure it. It says leading edge up there, and it's the edge down at the bottom down in there. Okay, so it's furthest away from the line, brightest part of the curve. Peak modal velocities I'll talk about. As I'm sure you know, the magic numbers are somewhere around 14 or 15. Some people suggest using it as this gray zone, right? So normal left atrial pressure in, circumstances where you don't have AF or bundle branch block, mitral line calcification or MR or whatever, significant regurg. If your E to E prime is less than 8, that is normal left atrial pressure. If it's greater than 14 or 15, and some people use 18 as a cutoff, that is suggestive of raised left atrial pressure, right? I think you need more information to kind of go in there with that, but it is a relatively standard thing that would say it is not perfect in the critically ill, but it's pretty good in patients with heart failure when they've compared it to wedge pressure, for example. But we mention it all the time. So an E to E prime of greater than 14 or 15 or 18, whichever one you want to use, that's starting to suggest left atrial pressure. And what you've got to do with that is then put it all into context, as we discussed a minute ago. Okay, so let's go back to our guys. We talked about normal pressures, and now let's talk about what happens if you start to get a bit older. So as you start to get a bit older, if that was our normal with our active relaxation and the normal operating compliance area, the thing that happens is we get, just watch the red line on this next bit. So as we get a bit older, this red line starts to change, and this active relaxation part starts sort of taking a little bit longer because the compliance starts to change. And that means that this left atrial pressure and compliance area starts to change, and we go from this normal area of this E to A ratio being about 0.8 to 1.5. It starts to change a little bit, and we get this change in this elongation of the active component because the compliance is starting to reduce. And that means that we get a pattern that looks like this, which we can call maybe mild diastolic dysfunction or grade 1 diastolic dysfunction, where the E wave starts to take a bit longer because of that impaired compliance. So we call this impaired relaxation phase or the impaired compliance phase. And we typically start to see the E to A ratio going less than 0.8 and this deceleration time being above 200 milliseconds. We see that when we start putting that with tissue Doppler, you'll start to see the tissue Doppler starting to, normally the E prime is bigger than the A prime, and here we can start to see the E prime being a little bit smaller. But you don't have horribly raised left atrial pressure, so often the E to E prime is less than 8. Okay, so this is what it looks like. Elongated E wave, so it's a bit longer. Decel time is a bit flatter. Okay, so you get the E to A ratio is normally less than 0.8, and the E to E prime is less than 8. Sorry, my computer's right. Sorry. Then we've moved on to, okay. Sorry, did I miss something? Excuse me. Okay. So now as we start to increase your atrial pressure, you'll see that waves start to rise. Okay. So as you start to get raised left atrial pressure, as things start to get worse, for example, if you're starting to get worsening compliance or more filling, you're actually then going to go back to this, to the E to A ratio that was round at being greater than 0.8 that we saw before. Okay. And this is where we start to get to moderate diastolic dysfunction. And the kicker is that it looks exactly like when the E to A ratio is like that when we were normal. All right. And we need more information to try and figure out if we've got raised left atrial pressure or not. And that's where the E to E prime comes in. So we can compare the E to E prime that will start to see it reduce. So if you've got an E and A ratio that are greater than this sort of the back to being a normal ratio, but you've got these markedly reduced E primes like we saw in that first case, this is where we can start to see this E to E prime value start to rise. And this is indicative of starting to get raised left atrial pressure. So as we look here, we've got the E to A ratio is back to being greater than 1.5. We can start to see an E to E prime maybe greater than 10, greater than 15, and we start to get that decel slope that starts to reduce again. And that is absolutely going to change as we start to get worse and worse with raising left atrial pressures, so with more fluid going on board or worsening LV relaxation. And here's when we start to see the E to A ratio go up and up and up, and we start to see the E to A ratio getting greater than 2. You see that E to E prime ratio reduce even further, and those E primes get smaller and smaller and smaller. And that's when you get these raised left atrial pressures with E to E primes greater than 15. Another thing that can help you looking into this is looking at your pulmonary veins. So here in this like APIC, imagine looking in an apical 4-chamber view. If you start to have a look at the pulmonary veins at the back of the heart, you get a flow that comes in during systole and you get a flow that comes in during diastole. And normally that S wave is bigger than your D wave. You'll see an atrial kick at the end of it, where you normally get a bit of flow going backwards, which is the AR, or the aortic valve, the atrial reversal. And we can look at the duration of that atrial reversal and compare it to our EA ratio and see how we go. Okay, so I'll show you an example of this. So what I tend to do with these guys is I put the color box over the back of the heart. I turn down my scale and I look to try and find the flow that comes in at the back of the heart. And it classically looks a little bit like this. I'll show you an example, it's a bit better here. So you can put your pulse rate Doppler at the back of the heart in that color flow area, and you can try and see a flow that looks like this. And this would be an example of systolic flow blunting. I recommend trying to narrow the image width, trying to have a small pulse wave Doppler gate, and just using that color Doppler to find the vein. Sometimes it's not quite as beautiful as that on 2D. And the differences that you'd see would be S and the D wave, which normally the S wave is a bit bigger than the D wave, and the atrial reversal is about the same size as the A wave. That's normal. As you're starting to get toward impaired relaxation, that duration is going to start to expand, okay? And the S wave will start to get smaller. So here you can see the smaller S wave and the smaller A wave duration compared to the AR reversal. As it gets even worse and more systolic blunting, that gets smaller and smaller as the atrial kick contributes less and less. So it's just another way you can start having a look at the severity of the diastolic dysfunction. All of this stuff is talked about in the best guidelines that we've got for non-critically ill patients, which is this the NAGWE guidelines on left ventricle diastolic dysfunction by the American Society of Echo. They've got these guidelines that I'm sure you've seen before, where A is those with normal left ventricle ejection fractions. You can look at all those parameters we started to talk about, the E to E prime, the septal E and lateral E prime velocities, the tricuspid regurg velocity, and your left atrial volume. And you can try to get an idea whether you've got normal or impaired diastolic function. If you have impaired diastolic dysfunction with more than 50% positive, you move into this second group. And that second group, it's all about just trying to figure out if you've got mild, moderate, or severe diastolic dysfunction, and particularly whether you've got raised left atrial pressure or not. It's I preferred these guidelines to 2009 because it left less room for ambiguity. And what I mean by that is it's rather than just relying on one value, which was the E to A ratio, this one's got an idea that you can actually pool them together. And particularly that's useful in the critically ill, I find, because sometimes the left atrial volume isn't dilated up. We've got to remember that there are a bunch of people we probably need to think about other things other than some of this. And that's patients with things like AF, bundle branch block, pacing, decent mitral annular calcification, significant valvular abnormalities, and things like that. I'll probably show you some more examples about that next week. So in the critically ill, some of this stuff is not perfect, as I'm sure you know. And Emma Bocock's done a really nice paper with Prof McLean talking about some of this, and it's quite a nice summary article about where the problems are with the critically ill. And if we look at these top 3 studies that she talks about in this is where they've actually, earlier studies where they've had a pulmonary artery occlusion pressure and they've had a left ventricle catheter in there as well. And what they started to show is that if we're using the pulmonary artery occlusion pressure as this reference standard, we started to see that as you start putting patients on more and more positive end expiratory pressure, some of the compliance issues or that relationship we see between left ventricular diastolic pressures and left atrial pressures can start to go. So we can start to see maybe that we've got some invasive measures that are not perfect when we're going to look at some of our, for example, because all of our diastolic dysfunction parameters have been assessed versus our pulmonary artery occlusion pressure. So it's a bit tricky to try and then say when you've got patients who are critically ill on significant amounts of PEEP, maybe we're not comparing apples with apples. When we start to look at our Doppler things versus pulmonary artery occlusion pressure, again, we've got some signs here that suggest that our Doppler parameters, they're not perfect with the diastolic dysfunction parameters that I've just spoken about. They're not perfect, as you can imagine, versus pulmonary artery occlusion pressure. And there are multiple reasons for that. First of all, our Doppler estimates, they are all going to be preload dependent. They're all going to be dependent on people imaging, and they're going to be, if we're considering comparing them to pulmonary artery occlusion pressures, we've got to remember that in these patients, there are multiple confounders to the accuracy of the pulmonary artery occlusion pressure, not least mitral valve pathologies and significant pulmonary valve pathology, because we're obviously measuring it in a pulmonary vein versus a left atrial pressure that's a fair way away from it. So worth having a look. It's a great article here by Emma, just talking about some of the problems that we've got with it, but make an argument that we don't have a lot else, and that's why I think it's worth having a look at. This is the best thing that we've got in most of our patients, particularly if we're not sticking pulmonary artery catheters in. We're just going to need to use all the information we possibly can. We've done a little bit of work of using these guidelines in patients with sepsis and septic shock. This is a pretty just simple slide just showing that when we use the newer guidelines from 2016, the reason why I like them is you've got much less indeterminants in there. The accuracy of these things we're not looking at here, but what we can say is at least we're not putting our hands up and saying we don't know. We're getting a bit more of an idea of whether we've got mild, moderate, or severe diastolic dysfunction. When we want to try and add in the accuracy of that, I think we have to start considering trying to put everything in context. And what I mean by that is I'll sort of point you towards having a read of some of the Filippo Sanfilippo's articles. And he's got a really nice idea that I absolutely buy in, that he says that you've got to kind of put diastolic dysfunction and sort of left atrial pressure estimate as part of a bundle, if you like. And he says that you've got to have a look at it based on things like looking at your chest x-ray and doing chest ultrasounds and seeing if you've got lots of B lines around or if you've got pleural effusions. You've got to consider it based on clinical grounds. Has this patient got significant features of shortness of breath and pulmonary congestion? Are they on a significant amount of vasoactives? Have they got significantly raised diastolic arterial pressures or ridiculously high heart rates or atrial fibrillation, all of which can point towards raised left atrial pressure? Are they on significant amounts of PEEP that you need that to try and make sure that their lungs don't get overloaded? And do you need to be considering them, clinically you think they're overloaded and you're trying to diurese them, you know, all of these things get put together with your ultrasound to make the assessment. And I totally buy that. You know, it's clinical context added in with echo assessment. So I'll show you a case. So 49-year-old guy with meningococcal septicemia. He's got a terrible looking uh, left ventricle function. You can see that he's got recovery, which obviously we didn't know at the time of assessing this guy, but we can look back and say that maybe we're dealing here with a septic cardiomyopathy, with this acute systolic dysfunction globally. Interestingly, he's got what looks like a raised left atrium. He's got a raised right ventricle. He's got a little bit of a pericardial effusion, all suggesting that maybe there's some potentially, you know, this dysfunction has been around for a little bit. We've got, you know, you can see this global LV dysfunction, this big left atrium, interatrial septum pushed to the right, all of which pointing towards raised left atrial pressure. We can see our medial E primes less than 8. We've got a lateral E prime that's less than 10. You've got an E to A ratio that's greater than 2, and you've got a big left atrium. And all of these things would point to the idea that you've got raised left ventricle end diastolic pressures from a septic cardiomyopathy. And Filippo and Landsberg and, you know, Antoine Ville-Baron, you know, all of these guys have done lots of research in this area and suggesting there's this strong association that if you've got these signs of impaired relaxation on these E primes and you've got a raised E to E prime, that is associated with worse outcomes in these critically ill patients. And that could be because of, you know, having such a high preload. This raised left atrial pressure keeps these patients on ventilation. And I guess it's not perfect. I don't think it's the be-all and end-all of assessing these guys' clinical status. I'm just saying it might be important to start considering this when we're starting to try and put it into the clinical situation. So what did I take away from those you know, simple measures that I took on this guy? Well, I kind of took away the idea that he's at risk of pulmonary edema. He's therefore at risk of spending too long on the ventilator. I'm thinking he's going to like the positive pressure ventilation. I reckon we need to diurese the hell out of that guy, and we need to think about our fluid balance. We need to wean the catecholamines as best we can before we even start trying to wean this guy from ventilation. So it's just a nice way of trying to talk about integrating clinical features with echo parameters. And then I guess let's take us on to next week, where we'll talk about left atrial pressure a bit more, and we'll talk about a few of the trickier cases, because it's nice and easy when their heart rates are normal. It's nice and easy when their E and their A is visible and they're not in atrial fibrillation and they don't have significant atrial fibrillation or tachycardia or mitral regurg or mitral calcification or right ventricle dilatation. And I'll show you some examples next week of how we can maybe start trying to look at left atrial pressure in those scenarios. And so we'll leave you with this lady, which is a 65-year-old lady. She's got lots and lots of risk factors for being a vasculopath. She's got some metabolic and respiratory acidosis from acute respiratory failure in ARDS. On lots of catecholamines, on lots of respiratory support, and she's getting this worsening hypoxia, and she's on close to maximal mechanical ventilation. If these guys have some form of impaired right ventricle function in there with that chest X-ray that looks like that, we've got to start thinking about whether we've got raised right ventricle afterload. And in these right ventricle afterload assessment, one of the things we look at is we can look at whether we've got this systolic notching, which is suggestive of pre-capillary pulmonary hypertension, as in, is it all the ARDS or the lung fibrosis or micro thrombi or too much PEEP, or, you know, it's all of these things that are sort of happening in this area of the capillaries that are causing that increase of that RV afterload that's putting all the stress on the heart? Or is it something to do with the other side? Because in the other side, it looks more like it's got a parabolic shape. You don't get that systolic notching. So you get more of this reduced pulmonary acceleration time, but you lose that notching. And this is where you have to start trying to assess whether you've got raised left atrial pressure or not. And that's also got to be linked in then with LV systolic function. So we're going to, you know, you've got to take everything that I said in this lecture about how to assess diastolic dysfunction with looking at your left ventricle function and your right ventricle function and your RV afterload, and you've got to put it all together in these critically ill patients, and we'll start looking into some of that a bit next week, okay? So I guess in conclusion, 45 minutes, close to on the nose. So in conclusion, I guess diastolic dysfunction is an active process. And that means that as you get older and your LV relaxation starts to become impaired, that process deteriorates. And that means that you are increasing risk of raised left atrial pressure as your LV relaxation impairs. And your LV relaxation will impair as you have hypertrophy, as you get reduced ejection fraction, as you get things like sepsis. Tissue Doppler is really important to look at, as well as things like your mitral inflow velocity. And it's also useful to use things like your deceleration time and using your pulmonary veins for analysis. And then that final thing is putting it all together with your clinical status of the patient. So we've got to look at things like their fluid balance, their respiratory embarrassment, clinical assessment, where they are in terms of their positive pressure ventilation, be it NIV or mechanical ventilation, and trying to put it all into the clinical picture with these guys. And as we start to either give them fluid or we're starting to take away fluid, you can reassess your left atrial pressure, and that can potentially things like your E to A ratio and your E to E prime, and you can look how they change over time to give you an idea whether you are winning or not. And we'll talk more about that next week. So I hope that was useful. That's a pretty whirlwind tour of diastolic dysfunction, and I'm very happy to take any questions that you guys might have. Are there any questions at all?
No, thanks, Sam. That was excellent. Really enjoyed that first
No
session.
problem at all.
Sorry.
Hi, nice to see you. It's nice to see you back.
I think it's always the difficulty of the crit care stuff versus the general literature, and just in general how we contend with PEEP all the time, how it confines nearly everything. I find that just I can't find right answers to this, but I like what you say about it. Just is another addition to all of the other aspects of your clinical approach to a patient. So, and probably fulfills the suspicions you already have or whatever.
Yeah, that's exactly right. I mean, I generally find that the diastolic dysfunction it's not often different to how I imagined it. Clinically, if you think of patients fluid overloaded, it's not really that surprising when you find an E to E prime that's bigger than 14, or you've got a big E to A ratio, or you've got reduced E prime values. I guess in my clinical practice, I use the E prime, particularly the medial one, if there's no mitral annular calcification. If that medial E prime is less than 8, there's impaired LV relaxation is kind of what I think, and therefore they are at risk of raised left atrial pressure. Yeah. I think the thing that I'm doing more and more in my clinical practice as I start to use it in those patients that I describe is the importance is repeating the analysis. So I do a quick point and shoot where you're just looking at the change in the E to A ratio after a fluid bolus. So for example, if you've got like a classic patient I was doing a couple of weeks ago when I was last on, you've got that it's the guy you're trying to keep out. I don't know whether this is politically correct to say this. The guy that you're trying to keep out of ICU, right? So it's like a post-surgical 72-year-old who's had some relatively minor surgery, and the anaesthetist says they can't get him off the 2 mils an hour of noradrenaline. And you're wanting to give this patient fluid, but they've got a history of HFpEF, they've got hypertension, they're known to have on an echo previously, they've got some hypertrophy. I will do a quick diastolic assessment of their left atrial pressure, and then I might give a bit of fluid and see if it starts to change a lot. Because if you see a big change, you're right on the border of starting to cause problems with diastolic with pulmonary edema from raised left atrial pressure. So I think it's that repeated analysis which I find useful. So you're not doing a whole study again and again, but just quickly looking at how things change over time. And maybe a more politically correct example I could have said, which would have been better, which would have been the weaning patients from mechanical ventilation. If you do a spontaneous breathing trial and you see their diastolic function flip round when you take away the positive pressure ventilation. These are guys who are going to get weaning-induced pulmonary edema, and that's what next week I'll show you all those examples. So yeah, that's a much better example I should have used rather than trying to keep a patient out of ICU. Forgive me.
Oh, thanks, Sam. That's brilliant.
No problem.
Sam, I have a question. Sick lungs tend to have B lines, whether that's from pulmonary edema or other causes.
Yeah, great call. Particularly COVID, right?
Yeah, and I just wonder how much you use your E to E prime to help differentiate cardiogenic from non-cardiogenic causes for that.
I'll put it all in, so the brief answer is, I think, as if you have someone who's got no mitral annular calcification, no bundled branch block, they're not tachycardic, they're not on a significant level of PEEP, and you've got, okay images, then you can start to use some of these diastolic dysfunction guidelines. I think as soon as you start to get on PEEPs greater than, let's say, 10 in some of the literature, like in Emma's article, or 15, then some of that E to E prime starts falling away. And I think you've got to start using all the other tools at your disposal. So the brief answer I maybe have to your question is that I don't use E to E prime in isolation in patients that are sick. So then you can use things like the stuff that I love using. My favorite would be the pulmonary vein analysis. If you've got that systolic blunting, you can't fake that as well. With your E to E prime, sometimes you worry that, if the gain's too high, your angle's off, or you got a bit of a shitty image. Those are all going to be confounders to your E to E prime. But if you've got a systolic, if you've got systolic blunting and the D1's really high, you can't fake that. That's someone who's got raised left atrial pressure. You can argue about if they've got a viral pneumonitis, or those B lines may or may not come from pulmonary edema. Then you've got to use everything else at your disposal. So the D cell time less than 140, your pulmonary veins, looking at changes as you take or give fluid, take away or give fluid, looking at the change. All of those things can just be another tool in your arsenal. And again, forgive me if I didn't say this earlier, I no way think that echo should be the be all and end all in this. It's just another tool that you've got to look after these sick patients. And I reckon in maybe 1 in 10, it's useful. Most of the time you probably don't need it, but every now and then it's got me out of trouble, and particularly with those guys that I'm weaning from mechanical ventilation or I'm worried about giving fluid to.
Thank you.
Were there any other questions, or can I give us back 10 minutes? Why don't we leave it at that if there are no other questions? Thank you very, very much for joining, guys, and see you next week. And we'll put this up online sometime, so you can have another listen to it if I've gone through things a bit too quickly.
Thanks, guys.
Thanks very much, guys. See you later. Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.